Welcome to our evidence summary, exploring the impact of probiotics on late-onset sepsis in very preterm infants. Please note that this video is an educational evidence summary and does not constitute patient-specific medical guidance. Late-onset sepsis remains a devastating hurdle in the NICU. Earlier signals suggested probiotics might protect against necrotizing enterocolitis, but the question was whether a 3-strain regimen could prevent systemic sepsis. We needed rigorous trial data to separate systemic infection outcomes from gastrointestinal protection. The Preterm's team enrolled over 1,000 very preterm infants across 12 centers in Australia and New Zealand. They followed these vulnerable infants through hospital discharge or term equivalents. That pragmatic approach gives us real-world confidence in the baseline data. This trial tested a specific 3-strain combination of Bifidobacterium infantis, Streptococcus thermophilus, and Bifidobacterium lactis. The active arm was paired against a matched placebo, with doses tied to enteral feeding volumes. We are evaluating a specific pharmacological formulation, not probiotics as a uniform class. The investigators used a stringent primary endpoint, definite culture-proven sepsis occurring after 48 hours of life, requiring at least 5 days of targeted antibiotics. This definition helps reduce diagnostic noise, but might overlook clinically driven infections without positive cultures. Regarding the primary outcome, the data did not show a statistically significant reduction in sepsis. With a relative risk of 0.81 and a p-value of 0.16, the confidence interval crossed 1. This result reminds us that an observed numerical difference is not the same as proven efficacy. However, we saw a striking secondary signal for necrotizing enterocolitis. The incidence of Bell stage 2 or greater dropped by more than half in the probiotic group, achieving a significant p-value of 0.03. While the local intestinal outcome improved, the precision of this finding remains modest. The treatment effect was not uniform across all outcomes. While there was no significant difference in overall mortality, a subgroup of infants born at or beyond 28 weeks gestation showed lower rates of sepsis. This remains a hypothesis-generating signal rather than a clinical directive. Statistical power was a limiting factor in this trial. The control group's sepsis rate was 16%, lower than the 23% assumed during planning. With fewer events than expected, the study had less headroom to detect the targeted effect. Probiotics are not a uniform class. We lack FDA-regulated, pharmaceutical-grade products in many regions, and clinical settings vary widely. We cannot support universal administration for all preterm infants, especially given FDA warnings regarding risks of invasive disease in fragile patients. In summary, the trial provided a clear NEC signal, but not a definitive sepsis signal. Success depends on the specific formulation, patient risk, and safety surveillance. Future head-to-head trials are needed to identify which products deliver a favorable balance of benefit and risk. This video is based on the following key references: the primary Preterm's trial in pediatrics, subsequent committee guidance on probiotic use, and FDA safety warnings.